I'm going to present a clinical case, and I will follow up on the patient intolerant to medication. So I have this patient at the hypertension clinic in Belgium. He's 61 years old, he's male and Caucasian, and he's referred by the GP to me for uncontrolled blood pressure. He's known with arterial hypertension for at least more than 5 years and still uncontrolled under medication for the last years because he had severe medication intolerance. There's dermatological proof of rash, eczema, and erythema nodosum, where I brought some pictures, so true medication intolerance. We do a medical history, and in the end it seems that his blood pressure has been uncontrolled already for 10 or 20 years, even more. He's dyslipidemic, he has a diabetes mellitus for over 10 years, he's obese, he's not smoking, and he recently decided to stop drinking any alcohol because he's read that this increases blood pressure. He tries to cycle twice a week, but it's an electric bike, and when I look at the ergometry, I don't think he's biking really hard. Family history: his parents have arterial hypertension, his sister has hypertension, and his grandmother suffered a stroke at 72. The antihypertensive medication that he's taking, he's on azaflow and rosuvastatin for prevention. He's taking valsartan 320 once daily, and he's taking nebivolol 5 milligram once daily because that's what he's been supporting for a couple years, and then 2 medications for his diabetes. Then I have the list of all the medication that he tried taking and where he had some kind of dermatological severe or less severe problem. I will not read them out loud, but I can tell you these are 21 pills that he tried together with his GP over the last years. So we have a problem. Physical examination, we have a BMI of 29.4. We have an average blood pressure of over 200 systolic and a heart rate of 66. Making me think that he's taking his nebivolol, and further a normal physical examination. Then we, of course, perform out-of-office measurements. The GP did it before referring, which was very good. And he has a mean 24-hour blood pressure of 158 over 96. And the home blood pressure measurements vary between 160 to 180 millimeters of mercury and 95 to 105 millimeters of mercury. We see that the day and the nighttime are increased, but that we do have a dip. The laboratory results come back and do not show us anything special, so I will go over them. And then we start the treatment, and we start, of course, with the discussion on the lifestyle. I will always start by explaining to the patient why it is important to treat his hypertension, why it is important in the next decennia. And we have a discussion about the physical activity. As I said, that I don't think that the cycling is of an important extent. The reduction in salt consumption, because he's eating a lot of food that has been industrially processed. So we discuss a healthy diet. I give the flyer, and we discuss that step 3 is also aiming for a normal weight. I dare to optimize the antihypertensive treatment, so I increase nebivolol to 5 milligram, and I start perindopril indapamide, and I discussed with him that I will call him back a few days later just to make sure that he's supporting this medication well, but I did dare to try. I call him back, and everything's going well, so I'm pretty happy, and we continue the medication, and I see him back for a first reevaluation. He increased physical activity and cycles now to work 3 times a week. I always try to convince the patient to put it into their daily schedule. It makes it easier. And he uses only the eco stand on his bike. He tried to look into the salt consumption. As I said, he reduced his alcohol consumption. Afterwards said that on parties, he was not always very good in reducing, so he now literally reduced his alcohol consumption. He paid attention to more healthy food, and he had a weight reduction of 3 kilogram. as said, medication was well tolerated so far. I think this was a couple weeks later, so I was convinced this was going to be fine. Blood pressures at home decreased as he was taking the medication, I guess. And his office average stayed pretty elevated, as was the previous time, so I expect him to have a white coat hypertension. The additional blood test that came back didn't show any secondary hypertension. Imaging didn't show any specialties on echocardiography or on renal arteries or adrenal glands. So secondary causes are excluded. We optimized the treatment again, and I reinforced the lifestyle measures. Explain again that for the lifestyle, we need to have and the weight and the diet and even more physical activity. And I dare to increase the perindopril indapamide to 5/1.25. And then we are obviously not there yet with the blood pressures. So I also start explaining a little bit the third option we have of renal denervation, as no other medication options are available anymore for this patient, as you have seen in the impressive list that he did not tolerate. I see him back another time, and he's now moving daily. So this is one of the rare patients that really took into account what we discussed and really started moving. He had a further reduction of 5 kilograms in body weight, and the medication was well tolerated. I performed an out-of-office blood pressure measurement, and as you can see, there is still a clearly increased blood pressure over the day, slightly decreased, decreased over the night, but we still have a problem with the blood pressure. So, as discussed, we again look into the renal denervation, and the patient is obviously fond of not trying any other medication and risking problems. I increase the dose of perindopril indapamide to the maximum dose, and I send him to renal denervation. When I see the patient back for the last time, we rediscuss lifetime, the pharmacological therapy, and we have an office blood pressure that went down. I think he got used to coming to my office, and now his blood pressure is a little better, although still increased, while the blood pressure at home after months, because this is months later, the third evaluation, really went down with renal denervation. So I have a happy 60-year-old patient that has been controlled under a combination therapy of lifestyle changes that were really well performed, which is important and rather seldomly done by the patients. I have optimal pharmacological therapy for this patient because that was complicated, and we have the renal denervation that helped us get into the blood pressure target range. Thank you for your attention.